and welcome to this program from the AIG Hospitals, Hyderabad. Today is an Anti-Obesity Day. In fact, in recent years, obesity and metabolic syndrome has become a pandemic among our population. They estimate that even in India, 30% of people are overweight. This leads to several diseases, and consequence of this is cardiac problems, pulmonary problems, gastric problems, fatty liver disease, and so on. Essentially, to fight this disease, we have several methods. Many of our patients come and ask us for surgery directly, but we know that that is a last resort. There are several steps towards this, and of course, we know that if effectively used, many of these can result in a marked reduction in the weight and of course cure of metabolic syndromes. Dr. Abhishek is chief of our obesity surgery unit, a bariatric surgeon who has been trained in Taiwan for many years, one of the leaders in this field in our country. He has written this very interesting book on treatment of obesity beyond surgery, and it's very unusual for a surgeon to write a book like this, where he deals with all aspects of obesity, how to overcome this, and finally what types of surgeries can be offered to these patients. This is going to be a landmark book in my opinion, written both for lay people and for doctors. And of course, I think this book is going to make a difference in your approach to how you treat obesity. Following this book's release, we are going to have a panel discussion by endocrinologists, diet specialists, of course a physician gastroenterologist, who are going to actually discuss about various aspects of obesity. So I think this is going to be an important landmark both for AIG and the Anti-Obesity Day we have today.
Thank you, Dr. Reddy. So on this occasion, we thought it is an apt day to release the book, which is beautifully compiled by Dr. Abhishek Katakwar. So I request Dr. Reddy, Chairman of AIG Hospitals, to kindly launch the book. I also request Dr. G.V. Rao, Director of AIG Hospitals, to do the honors.
Come. Nitin, come. Chandana, come. Monica, come. Sir.
Okay. Thank you.
Thank you, sir.
Thank you, sir.
Good evening and welcome to AIG Hospitals. On this World Obesity Day, there are a lot of activities that are going on across the globe, trying to create awareness regarding obesity, medical, non-medical, social, environmental. All these issues are being dealt with by various agencies across the globe. Because we all know that obesity is a pandemic, and this is a thing that has created a lot of attention worldwide, and a lot of agencies are trying to create awareness among this obesity to make sure that the next generation lives beyond the average lifespan that the current generation lives up to. As a part of this awareness, we see that a lot of training centers or health centers that have come up across the world, and these are manned by people who are called as wellness trainers. We understand that these wellness trainers have had a certificate course from various agencies, but for the first ever time, AIG Hospitals has taken this initiative to start a course when the doctors get involved in this training program, which we feel is very important in training these trainers who ultimately are training the people who are coming to the wellness centers. There seem to be some loss of disconnect between the trainers and the doctors, because a lot of scientific information that is there in the literature is not truly practiced in real sense when it comes to training these people who come to the training centers. As an example, we can give you that actually of late you must have seen in the news that almost about 4 to 5 prominent actors who have been training in wellness centers have died because of improper guidance. It is likely that these people have not taken proper guidance from their concerned doctors before hitting onto these exercising activities in the centers. We as doctors, we personally believe that actually everybody who goes on to these training centers or who want to lose their weight in the training centers, I think need to get a prior consultation with the doctors to make sure that the whole thing can be programmed in such a way that these people do not have any untoward efforts during this entire training sessions. The other thing that happens is actually there seems to be a disconnect between the trainers and the dietitians. Of late, actually, we see a lot of these people who hit the training centers coming up with a lot of GI problems, predominantly related to constipation and the effects of constipation, including hemorrhoids, fissures, fistulas. This basically seems to be because actually the dietitians seem to be putting these people on real high protein diet without advising about proper fiber intake at the same time. This we feel is a very strong thing which is going to change, because this is hitting their hours of life in their routine clinical thing, and majority of these people are not able to attend to their regular duties because of these gastrointestinal issues. As a part of this, for the first ever time, AIG has decided to start an AIG certified wellness trainer center, wherein these trainers can get registered online and they go through a standard format of training under supervision of doctors. We have very well trained doctors, actually of national, international repute. Dr. Abhishek, Dr. Rakesh, who head the Department of Obesity and Metabolic Surgery, who have been spending a lot of man hours to make sure that this awareness is passed on to the people. I'm sure their expertise will help these trainers to properly guide these people who come to their centers. I'm absolutely sure that actually if you follow this training centers, which is going to be for about 6 weeks, subsequently you'll get certified that you are an officially wellness trainer certified from AIG Hospitals. This would be of a great importance not only to you but also to the people who are coming to the training centers to get trained under you. We all hope to create a good environment between these trainers and your clients, and let them not become their patient, let them be your client. We don't want them to become patients and come down to our centers. So I think a proper training course like this would be of immense benefit to everybody. So I congratulate Abhishek, Rakesh for formatting this entire course, which is for the first ever time very well formatted course. It is going to be advertised on the social media and also circulated in the electronic print media. People can get registered on this. I think you should avail this opportunity, and I'm sure that will be of immense benefit to the patient population. With this, we formally inaugurate this AIG Certified Wellness Trainer program from AIG Hospitals. And again, congratulations to the entire team led by Abhishek and Dr. Rakesh and the other staff who are helping them in this program. Thank you so much once again.
Thank you so much, Dr. G.V. Rao, Director, Surgical Specialty. It's an honor to have you here, sir. And I'm sure this program will be of great value. So let's start today's meeting with why it is difficult to lose weight if you're an obese person, and even if you're trying, why does it fail all the time? So we want to keep it very short and patient oriented. The whole talk will be very short and patient oriented because we want to focus more on the panel discussion, which is mostly the question answer based thing. And please keep posting your questions on the live social media comment section so that we can answer it immediately. Or else you can drop a message so that our team will get back to you with the answers. So most of us have this feeling that, I initially lost weight with diet and exercise, but now it is constant, and no matter how much efforts I put, it is very frustrating. I'm not losing any weight despite of whatever methods I'm trying. And this is a very common question. We see a lot of patients coming to us with the same question, and probably everybody has a similar situation. Now in my talk, you will see some keywords. One of them is compensatory behavior. I'll speak about it later. Another is metabolic adaptation. The third is weight loss plateau. And the fourth is set point. Now compensatory behavior is a behavior which happens when you hit the gym. Then you try to compensate for that gymming activity by doing something which is not good for you. Like you took the gym, but then you want to take the lift because you already hit the gym. You want to compensate on the diet because you already did your workout, so you feel that, okay, I deserve to eat more. Metabolic adaptation is something which happens over a period of time when you want to lose weight, but there is a lot of hormonal changes which happens because losing weight is anti-natural. The moment you start losing weight, after a certain age and after a certain period of weight you have gained, your body goes under adaptation and then it resists any weight loss. Weight loss plateau is something which happens when you try to lose weight. Initial phase is very fantastic. You're very happy about losing 5-6 kgs weight in initial few weeks, but then no matter how much effort you put, you don't lose weight. That is called weight loss plateau. And weight loss plateau is important because every time you reach a weight loss plateau, it becomes difficult for you to go beyond that point. Set point theory is a theory which is now mostly accepted because it says that your brain has adapted to a certain weight. Like we have, the hypothalamus has a set point for temperature. Everybody has a different perception for temperature. Similarly, your hypothalamus has a different perception for different individuals. The moment you try to change that set point, again the brain does not accept it. So these are the physiological problems which happens when you try to intentionally lose weight. And unfortunately, obesity has been thought to be related to imbalance between energy intake and the expenditure, which has been proved wrong. For years, we have believed that energy in, energy out imbalance causes obesity. Now we know that there are more things to understand, including metabolic derangements, hormonal imbalance cascade, genetic polymorphism, physiological or environmental triggers which is happening. We have been made addict to use latest technology and IT. Everybody can get their food at home. Behavioral factors also matters a lot. And I was talking about why it is difficult to lose weight, because when you look at here, the resting metabolic rate is the most important, and we call it basal metabolic rate. So when you try to change things, the most of the thing which can change in the non-resting energy expenditure, but there is little bit change happening in the basal metabolic rate. And the moment you try to change that, your body adopts and it slows down your basal metabolic rate, and this is how you achieve a weight loss plateau and then you don't lose weight. Now metabolic adaptation, I was talking about. What is metabolic adaptation? It is change in your hormones. So anabolic hormones, anexorogenic hormones, thermogenic hormones, these are the hormones which changes. And obviously you become more hungry, the catabolic hormones increases. And this is what is considered as metabolic adaptation, which causes imbalance. You have fatigueness, you have fogginess, anxiety, irritability, depression when you try to lose weight. Obviously, more cravings, poor sleep, sweating, insomnia, these are the symptoms. So the fact is, dieting and exercise, if you have crossed a certain limit of weight, then dieting and exercises decreases your metabolism, increases your hunger and craving. Obviously, age is another factor which causes change in the metabolism. And it is anti-natural or anti-survival to lose weight, because if we remember when the lockdown was announced, the first thing we did was we went to the grocery store and we dumped everything, no matter whether we are going to eat it or not. The same thing happens when you try to lose weight. Your body goes into a panic mode and it tries to store more for future, and this is how you gain or rebound weight regain happen. Set point, I've already spoken about how the set points are important. So if any of you are struggling with obesity and diabetes and not losing weight, then definitely you should come and meet us in our Center for Obesity and Metabolic Therapy, and we will definitely try to help you out. Now I would like to invite our second speaker, Dr. Nitin Jagtap. He's part of the team, and he's endoscopist. He does a lot of work on the bariatric endoscopy. So over to you, Dr. Nitin.
Now we will move to what are recent or new changes in management of obesity. So good evening all. So the obesity is ongoing pandemic. Though we have come out of the COVID pandemic, this obesity is the real and ongoing pandemic. As you can see, the rate of obesity has tripled in last 3 decades. And majority of time, the complications of obesity such as cardiac diseases, NFLD related liver cirrhosis are being treated with highest possible therapies such as liver transplant, coronary stenting or bypass surgeries. But the root cause of the disease, which is obesity, is not treated in many types. This is the one of the study from USA, which has shown that less than 1% of obese patients received medicines for obesity or underwent bariatric surgery over a follow-up period of 3 years. And this is not different in India too. So the obesity remains undertreated and underdiagnosed. What happened in India in previous 10 years or so, the rate of obesity is almost doubled, not only in males and females, but also in our rural population also. So there are various treatments now being tested for obesity, and out of which few are drugs, injectables. Majority of these drugs are not yet available in India, and the bariatric surgery, which is commonly performed, can give rise to more than 30% of weight loss. And there is still a large gap exist between these two, and this gap can be filled with endoscopic therapies. So I'll just go across what are the few endoscopic therapies that are routinely performed at our center. The majority of balloons which is available are static. They can't, the intragastric balloon, which is the balloon which is placed in the stomach, and that can over a time reduce up to 15 to 20% of weight. This is the special balloon in which the volume inside the balloon can be adjusted, so that if you are getting plateau at after some time, the volume can be adjusted and you will lose more weight. There are different types of balloons which don't require endoscopic placement, such as this ellipse balloon, and after 3 to 4 months this balloon can excrete spontaneously. So this is completely procedure-less balloon, but long-term results are not that good for this balloon. Coming to the second part where we can do a surgical procedure by endoscopic without any incision on your abdomen. So this procedure is called endoscopic sleeve gastroplasty, in which the right side you can see laparoscopic sleeve gastrectomy, in which the part of stomach is being cut away, and the similar anatomy can be achieved with the endoscopic treatment, in which the stomach is sutured from inside with the endoscope through the mouth. So this is the graphical presentation of the same procedure, in which we go inside the stomach with the endoscope and suturing device, and from distal part we start suturing and over coming back towards the food pipe, and we can have ultimately the reduction in the size of the stomach. So this procedure is repeated, and eventually you will get the globular stomach will change into the tubular stomach, and this procedure can with this procedure you can reduce up to 25% of your weight. So this procedure at the end look like this. The globular stomach will be tubularized. There are few other endoscopic therapies which have come up. There is new modifications of this procedure has come up, and which can give rise to more weight loss and sustained weight loss. I will come to this interesting part. Many people tend to skip a breakfast to reduce weight, and this is the recent study published few weeks ago, which has shown that each breakfast keepers and those who eat late lunch are associated with more obesity, and this association is independent of age, gender, even with the physical activity. So to conclude, the unmet needs of obesity management, endoscopic therapies is the answer because they are safe, effective, can be reversible and can be repeated if required. Thank you. I'll ask Monica to start next session.
Hello everyone. On the occasion of Anti-Obesity Day, I am going to discuss about support group meeting. We proudly announce that we were the first center who are conducting support group meetings in obesity department. Since 2015, we are conducting the support group meetings at AIG platform. Today I am going to discuss about the support group meeting. So whenever we say about support group meetings, there are few questions come from the patient point of view. The first question will come, what is the concept of support group meeting and what these people will do at the support group meeting and what is the use of the support group meeting. So today I am trying to clarify all those questions. The first thing will come to the concept of support group meeting. Support group is a meeting is a gathering of people facing common issues and sharing of experiences, support and motivation. This will help you to give the opportunity to connect with people in similar situations, to find people who provide us with understanding, compassion and encouragement. It's also help you to attending a support group meeting is a great way to stay on track, learn new things. The next question will come, what happens at a support group meeting? So we know that obesity is the root cause of so many issues. When we discuss about obesity, there are a lot of problems, not only the physical issues, at the same time it will come to the mental issues also. Mental health is very important. So every time whenever we conduct a support group meeting, we invite guest speakers on various topics such as the physical exercise, healthy recipes, healthy eating and psychological issues and economical issues as well. And patients will share their own experiences which will help and motivate others who are on the same path. It also provides an important element of accountability and an opportunity to reconnect or rededicate to long-term goals. And how will a support group meeting will help? First, you realize you are not the only one who has challenges. It offers a way to learn from the people experiences who are already underwent any kind of procedure or doing any obesity regimen. And it is not uncommon to slip back to old habits, regain weight and become discouraged. If that happens, support group meeting will play a very important role. So it will give you to help to be and stay focused and become a successful in a weight loss journey. And patients who attend regularly, they achieve greater weight loss than the others. If you need to be educated, motivated or rededicated, you will have to attend a support group meeting. And finally, it will come to how often do we conduct. So once in every 3 months. In COVID times also we conducted support group meeting on online basis. And the conclusion, in short, it will be a regular boost to your energy and momentum towards health. Sharing this common interest with others can help you to stay committed and to make healthy choices for yourself. So these are the pictures which we used to conduct earlier. So we also used to show the recipes which are very healthy and you can make it at home, and we'll show the physical exercise protocols. We used to, it will help you to correct your postures and you can able to do it at home. And finally, whenever we conduct a support group meeting, we'll share all the register information on our AIG portal. Anybody interested, you can do register there and it's free of cost. And thank you.
Thank you, Monica. Yeah, I'm audible? Yeah, thank you, Monica, for the nice presentation. Now we'll move on to the next interactive panel discussion session. So, as we all know, obesity is a chronic relapsing disease and it used to be a disease for richer people. That's what was earlier the belief. But now it has become a disease or a condition both for poor and rich. So probably after the green revolution, the rice production started increasing and there is easy availability of junk foods even in the remote areas. And also people started spending much time watching TV and gadgets and started eating, and they keep on eating. And more or less majority of the people don't know about the adverse effects of being obese. So it's like in Hindi they say khate pite gar ke hain. So it's no more it's like a myth which you have to get out of your mind, you know, because as you see the pandemic from last 2.5 years, what happened with COVID, majority of the deaths were people who were obese. So it's a big catastrophe to be obese. And also obesity in children, in fact we can say it's mother's ignorance of the child being obese, because you know a child is being fed even after he grows with mother, and so mother should be you know knowledgeful enough that obesity is a very bad disease for the child once he grows up and then goes long. In fact, the interesting part is in 2008 the Japanese government has come up with a law saying that being obese is illegal and you can be punished. I mean, you don't be punished exactly, but you know they'll be called and counseled. So that's the strictness of what in fact that's the reason why Japan is a country which has got the least obese population. So anyway, coming to the discussion in proper, we thought we'll have a panel discussion, an interactive session, and we welcome the audience if you have any questions to post. So myself, Dr. Rakesh Kalapala, I am the Director of Center for Obesity and Metabolic Therapy Endoscopy part. On to my left is my Associate Director, Dr. Nitin Jagtap, who is also a gastroenterologist and endoscopist. On to my right is Dr. Abhishek, the Head of Bariatric Surgery, Center for Obesity and Metabolic Therapy. And on the last is Dr. Chandana, who is an endocrinologist, who also is one of the key persons who will manage our people with obesity and diabetes. So without wasting time, I'll start the ball rolling. So I think first we'll start with Chandana. Chandana, we have seen a lot of hue and cry in the recent past about the drugs that are used in obesity, diabetes or diabesity, what we call. Yes. So diabetes anyway is a different topic. So what is your message, what you want to give, or what is the current literature and scientific scenario on these drugs for obesity?
Okay, so good evening everyone. So when we are looking at drugs for obesity, Indian cutoffs for BMI are lower compared to the Western world. In India, we take a cutoff of 25 kg per meter square as the cutoff for obesity. More than 25 kg per meter square is considered obese, whereas in Western world it's a higher cutoff of 30. So when we start management for pharmacotherapy for obesity, we take a cutoff of 27 kg per meter square for patient who's just obese with no other comorbidities, or if the patient has more than 25 kg per meter square of BMI with other comorbidities like diabetes or hypertension or OSA. So in this condition, we take a lower cutoff for starting a patient on management of obesity with pharmacotherapy. So when the drugs which are available for management for obesity, plain obesity in India, it's only Orlistat has been approved. It's a lipase inhibitor and it usually acts on the gut. It inhibits the lipase in the digestive system, so there's decreased absorption. But the problem is the patient usually has a lot of oily stools and a lot of anal incontinence also can happen. But then with this drug, weight loss has been seen and about 5 to 10% of weight loss can be seen. So this is the one drug which has been approved in India, but there are other injectables like liraglutide or semaglutide which is not yet approved in India, and other oral drugs are also available which are not approved in India like the phenetramine, topiramate, which is not yet available in India. So these are the medication. The only medication which is available for plain obesity management is Orlistat. But when we look at a patient who has diabetes and obesity, the diabesity, we have a spectrum of drugs right now. So we look at the first option which we choose is the GLP-1 receptor agonist. So we have liraglutide, dulaglutide. The liraglutide is a daily injection. Dulaglutide is a weekly once injection, and now we have the oral semaglutide, which is again a daily oral tablet. The side effects of oral GLP-1 receptor agonists are usually they have mild nausea, vomiting, which usually settles down, and some other GI disturbances. And the other group of drugs which can be used for weight loss in diabetic patients are the SGLT2 inhibitors, like the canagliflozin, dapagliflozin, or the empagliflozin.
Right. Thank you, Chanda. So, this is a long list of drugs, but only thing is the safety also is very important, because a person who starts this drug should not end up in side effects. So, I think what we have, the message has to be given to the audience is, you should not start haphazardly without any proper specialist care who will monitor them. So, that's very important.
This has to be done. All this medication has to be started under the doctor's guidance only,
Yeah.
and under proper follow-up.
Yeah.
Because when we start a patient on this medication, we look up at how the weight loss is happening. If the patient has a good weight loss, at least about 5% in the next 3 months, that means the drug is effective. If it is not happening, then we need to look at other ways of managing the patient.
Sure, yeah, that's something which we have to tell them, because there are a lot of people in the peripheries who start these drugs without any rationale,
that
and
is
then they end up with a lot of side effects instead of positive effects.
True.
Right, thank you. So, my next question, I'll go on to Dr. Nitin. So, Nitin, when do you advocate these bariatric endoscopic procedures?
So there are various.
In which set of patients?
So thank you, Dr. Rakesh. So there are various procedures which can be done endoscopically are now available in India, out of which are the patients who are candidate. As Dr. Channa has already said, the cutoffs for BMI in Indian patients are lower. So at our center we select patients those who are having BMI more than 27.5 with obesity related comorbidities for bariatric procedures, or BMI more than 30 without any obesity related comorbidities such as diabetes, dyslipidemia, hypertension, etc.
Okay. And see, in this, I think I'll come to you later. So now I'll go to Dr. Abhishek. So Abhishek, when do you suggest surgical management? Suppose a person is standalone obese, or standalone diabetic, or obesity with diabetes?
So again, we have guidelines from ASMBS, IFSO guidelines, and also South Asia Pacific guidelines. So I'll tell you about the Indian guidelines. Any patient who is more than 27.5 and diabetic is a candidate for metabolic surgery. Any patient with more than BMI of more than 32.5 and comorbidities is a patient for bariatric surgery. And any patient who has BMI of more than 35 without comorbidities is a patient for bariatric surgery standalone. So now the guidelines have been revised, and in a recent publication they are coming up with further discussion on how to bring down more people under this category, because they shouldn't be deprived of the treatment option, because guidelines will decide whether insurance companies are going to pay for or not. So these guidelines have to be made accordingly, where patients can get benefit also if they are suffering from obesity.
Okay. So now we'll move on to again the drugs part. So I'll ask Dr. Chandana. So these new drugs which are available, they have the injectable forms, and oral of course is available, I think, only in India, the semaglutide.
Yes,
As you told in my previous question and answer, so this orlistat I think is being less used now compared to the previous ones, and phentermine, topiramine, we don't have it, and we don't advocate that also. In between liraglutide and semaglutide, which one you prefer? Number one. Number two, what is the acceptance of injectable forms in Indian population according to experience?
So liraglutide has been in the market earlier. So it's being given, it's a daily injection which we give. So for obesity management, we give it at a higher dose of 3 mg per day. And acceptance, as we know, injectables people don't prefer. They think, why do we need to take an injection for this? So, but still, those who are very motivated, they'll go ahead and take the injection. So when we compare with the oral semaglutide, which has come recently, so when we compare between the oral semaglutide and the liraglutide injection, the weight loss is similar between both of them. And once the oral semaglutide has come, the changeover from liraglutide to semaglutide has increased. Actually, most of the patients who are on liraglutide would come and say that we would prefer to go on to the oral medication right now. And the efficacy is similar. And when we look at the side effects also, the side effect portfolio also is both similar. Both are in the same group, both are GLP-1 receptor agonists. So the GI side effects are the only ones which are usually seen with these drugs. A little of nausea, vomiting, and loss of appetite. So as of now, a lot of people are changing over to the oral medication.
Okay. So the acceptance is more for oral medications. Yes. Right. So Nitin, this is for you. So we know there are two currently acceptable procedures in endoscopic bariatric therapy. One is the balloons and one is the endoscopic sleeve gastroplasty. So how effective are these balloons, number one, and what is the tolerance capacity or acceptance for a patient to put a balloon inside? And again, in the same question, who are the people who are really, specific set of people who benefit with balloons?
So the balloons which are like intragastric, these are intragastric space occupying balloons which we put through the endoscopy, and they will stay in the stomach for 6 months. There are few newer balloons for different companies which can stay in stomach for up to 1 year. And the well motivated patient can tolerate balloon very well. For initial 1 week or so, they will have some nausea or vomiting, but once this initial nausea vomiting subsides, the majority of people can tolerate the balloon. However, in the literature, there is still 5 to 7% chance that these people require early removal because of intolerance. And to get rid of this intolerance, there is special type of balloon which is having additional tube attached to the balloon, and that tube can be again endoscopically the balloon volume can be adjusted in between if required. So the majority balloon, those where are static, if you put 500 ml of balloon inside the stomach and patient is intolerant to balloon, then you have to remove that balloon. But this adjustable balloon, what you can do is, we can just go ahead go again inside the stomach, remove some part of the liquid, and the patient can tolerate the balloon for longer time. And the recent study has shown that in very well. Also, if after some time balloon patients can tend to have a static weight loss, the weight comes to plateau. In these patients, we can go ahead and infuse more liquid into the balloon and can get more weight loss.
Okay. Thanks, Nitin. So I think balloons are ones which are innocuous and have a good results, but again you have to be specific in who they will really be beneficial, and probably people who have got a binge eating habits, they might not be very ideal candidates for balloon, because once you remove the balloon, then again they start eating and regain weight. Okay. So Abhishek, then another thing is there are a lot of surgical procedures in bariatric surgery. So how do you choose which procedure suits to a particular specific condition, and which is best for the particular patient?
So
I just in very short, because you should not confuse them.
Yeah, it's a very important question. Why there are so many procedures? Yeah. Because none of them is perfect. That's the first answer. And we decide which procedure will suit best depending on so many factors, starting from history to lifestyle. How is this family support? How is the eating behavior? Whether patient is a smoker, non-smoker, sugar craving, and psychological problem. So there are so many things which we have to consider, and depending on that, we decide which procedure will be best for the patient. But I'll tell you in brief, sleeve gastrectomy is a procedure in which we take out approximately 70 to 80% of stomach. This procedure is worldwide the most common procedure. We usually recommend this procedure for young girls who want to have a childbearing age later. We usually recommend this procedure for BMI below 40 and patients who don't want malabsorptive procedure despite having more BMI. Another procedure is called gastric bypass. There are two types, Roux-en-Y gastric bypass and mini gastric bypass. These procedures are reserved for patients with high BMI and patients who are diabetic also. But these procedures are contraindicated in patients who had a family history of gastric cancer or who have reflux to an extent of grade B or grade C, and patient with severe liver failure. These patients cannot undergo bypass. The third procedure, which is mostly called metabolic surgery, which is reserved for patients who are diabetic. They are very advanced procedure, and mind it, all these procedures are done by laparoscopy. I have seen people saying that, in fact, a lot of people don't know that these procedures are done laparoscopically, not by open surgery. So that should be very clear. All bariatric procedures are done by laparoscopy.
Thank you. So I think they have some few online questions also. So there's one I think which is very relevant. See, not every person who is obese is a binge eater, or it happens only with the food habits. There are other causes of obesity, which unfortunately any obese person, people in society will label them and then tease them that, he's a heavy eater and all. So Chandana, if the person is a very poor eater or he has control, he or she still can be obese. So what are the other causes of being obese apart from not the eating behaviors? Those are very important. And I think you as endocrinologists play a vital role in that. And any person who is obese should not start restricting themselves and then trying to lose weight. You also, especially female population, should approach an endocrinologist or a physician and then understand what else other than eating habits. So can you just elaborate on that?
So when a patient comes with us with obesity, so it needn't be just because the patient is eating more, as we were talking. There are a lot of endocrine causes of obesity. So we need to look at the endocrine causes which can, and we need to rule them out before we consider the patient to be just obese and start on obesity management alone. So we need to look at whether the patient has hypothyroidism, if she's a female, whether she has PCOS, if the patient has Cushing's, whether the patient has been on steroids, and that could be because that could cause a Cushing syndrome, whether the patient has a Cushing's disease because of increased ACTH production in the body. So, and whether there are any other genetic causes. There are a few genetic causes of obesity also which we need to look. They are very rare, but we still need to look into that in case the patient is coming with, like you said, with no appetite, not binge eating, but still the patient is obese. Yeah. Like for example, I can give you just the other day, I got a patient. So this lady, she was telling that she's not been eating much and she was very slim 2 years ago. And now she's become very obese and she's got multiple weakness and she's not doing well. And she's got menstrual disturbances also, she's got bruising, she's become very chubbier. So when I looked at her, thankfully her relatives noticed and have brought her, but when I looked at her, I realized this is not just plain obese. Yeah, she has an endocrine problem. Most probably she could be a patient of Cushing's disease. Exactly. So we should not just plainly consider all obese to be just because of increased eating. So
you should not try to starve yourself, try some diets and then even make the condition more worse. Yes. So that's, I think, the good message what we have to send.
I have a question for her,
yeah,
if I may ask. So what are the contraindications for weight loss drug? I think it's an important question. And how long you can give this medication to the patient?
So like I said, so when we start a weight loss medication, we start, the contraindications like orlistat is just a GI thing, not much of contraindications, but when GLP-1 receptor agonists, there are contraindications if the patient has a history of medullary thyroid cancer disease, of the family history of medullary thyroid cancer disease, if the patient has history of pancreatitis. In such situations, we do not give the GLP-1 receptor agonists, which are presently being used.
Including type 1 diabetes.
Including type 1 diabetes is not at all indicated.
Yeah. So that's very important. So that's the reason why we re-emphasize again that you don't start these drugs without a proper specialist consultation and constant supervision. That's very important.
And another thing, if we want follow-up, if we don't notice at least a 5% weight loss in the next 3 months, that means the weight reduction is not good, the drug is not effective for the patient, and we can consider withdrawing the drug for the patient.
Thank you. So now I'll move on to Nitin. So Nitin, there is something called as endoscopic sleeve gastroplasty. So that is suturing of the stomach with endoscopy, and which is like the laparoscopic sleeve gastrectomy. So how safe is this and how effective is this? Because many of the people don't know, and it's upcoming, or of course now we have enough literature on this, but how safe is this procedure and how effective is this procedure in a given scenario?
So endoscopic sleeve gastroplasty, which is known as ESG, is being performed worldwide since more than a decade now, and we have a robust data from throughout the world, out of which the recent RCT has shown the adequate weight loss of
Randomized control trial.
randomized control trial done in more than 15 centers in USA has shown that as compared to the lifestyle modification, the endoscopic sleeve gastroplasty can give more than 20% of total body weight loss, and this weight loss is maintained for more than 2 years. And those patients who were following for initial period for lifestyle modification, the chances of them losing weight are less as compared to the ESG therapies. And these patients, after 1 year, they were offered endoscopic sleeve gastroplasty. Out of 100 odd patients, 95 patients chose for endoscopic sleeve gastroplasty. So this procedure is safe and effective in sense it can give rise to give us more than 20% of total body weight loss, and safe in sense this therapy is a total day care procedure. Patient comes in the morning at a hospital, we do procedure till the evening, we observe. At evening he can start clear liquids and go home.
Yeah.
So there will be mild pain, but that will subside with simple medicines such as paracetamol alone.
So by and large, it's a safe procedure, but again, it's not that we are telling it's going to be at par with surgery, but again, there's a subset of population who may have to choose properly and then advocate them this. Okay, thank you. So see, we are all talking about so many procedures, surgeries, endoscopies, and pharmacological therapy and all. But I'll tell you one thing: the basic crux of this whole story is, one, the motivation of the patient to lose weight, and two, the patient should, if they lose weight, they also should have the motivation to sustain the weight loss. You do some of these artificial things, you make them lose weight, and if you start eating again, they'll regain weight. So the main thing is, it should come from the patient's mindset. And also, it's not that every patient who is obese, we are trying to push them into these artificial things and then get the procedures done. Obviously, lifestyle modification is the best, and in fact, for that you need a good nutritionist support and also a psychology or a psychotherapist support. Why I'm telling you is, any bariatric program works and will give the best results when you have a team approach. You should have a surgeon, physician, gastroenterologist, endocrinologist, nutritionist, then clinical psychologist, and a psychiatrist. These all should work together and give a comprehensive workup should be done, and a holistic care should be given. So that is what we at AIG are looking forward, and that's the reason why the Center for Obesity and Metabolic Sciences, the main aim and purpose of doing this is, it's a holistic approach for any obese person. I don't say obese patient, obese person. So that's how you have to work, and then that will give the best results. So I'll just move on to Abhishek for another question. Abhishek, people have got a lot of apprehensions with the side effects of this bariatric surgery. Is it true?
So when bariatric surgery came into picture 20-30 years back, yes, there were some concern. But now technology has evolved. The surgical time has gone drastically down. We finish almost all kind of procedure within 1 hour to 1.5 hours. So anesthesia time has reduced. So perioperative comorbidity has reduced. And also the nutritional problems can be managed if patient is under supervision and follow-up. That's why we already mentioned about the support group program which we routinely conduct, because nutritional problems can be handled very, in a very profound way if a patient is under follow-up. That's why our team continuously keep on working on how to engage this patient post-operatively. And I would like to mention here that we were talking about the comorbidity and other things. We have been doing this procedure since last 10 years, and we did not have any mortality or any death due to surgery or after surgery. In fact, our readmission rate after surgery is hardly 1%, and that too not because of the complication, but sometimes patients are apprehensive they think that they might have leak or bleed, and then they come to us and we want to give them a comfort, and we tell them that okay, we'll do some investigation. So far we did not have faced any such severe complications or comorbidity which is been published in the literature in the past. And obviously the credit goes to the multidisciplinary team, as you already mentioned. There is a very strong network of physician, intensivists, critical care, physiotherapists, and all of them play a very pivotal role in maintaining such a good track record.
Thank you. So I think the take-home message from this panel discussion is we can fight against obesity, and obesity is a chronic disease. So you need to have a sustained improvement in your lifestyle, then the food habits, and what I can tell is prevention is better than cure, as the old age saying goes. So don't get into the obese bracket and then try to reduce weight with all these fancy means and artificial things. Instead of that, try not to become obese. It's as simple as that. Once you become obese, once you gain weight, it's very difficult to lose. So, all said and done, we can sit on the other side of the table and then give big lectures and all. But if you see a patient, a person who is obese, we know how much of pain they take to lose the weight. So instead of that, don't try to get into the obese bracket and save yourself. And obesity is a chronic disease, and we all are trying to fight against. There are a lot of research going on to try to address this population with the minimally invasive procedures, and even a lot of pharma related drugs are also in the pipeline. So let's see what best we can do, and we at AIG Hospitals have great infrastructure with all the specialists working under one roof and giving a holistic solution for the people who are obese. Let's see what best we can do in the next 1 to 2 decades, and I am sure India as a country is developing in other means equal to what the obesity is growing on. So let's try to fight against obesity and give the best to the people. Thank you. Thank you all for participating, and I thank you all the people from AIG to giving us the opportunity. Thank you once again.
Thank you.